Hello, welcome to the first day of HOPA. My name is Edward Lee, a director of health economics and outcomes research at Sandoz. And today we have a really great presentation. It's been just a really strange year, and I've never thought that I'd be moderating a session at HOPA virtually, and I won't really comment about how much further this year has been strange, but I do want to comment that perhaps we've all chosen our backgrounds or virtual backgrounds. As you can see, I've got this nice plain peach-colored background that I thought, in my mind, looking at the swatch, was a nice beige one. So I'm channeling my John Oliver there. But today we have a great presentation, this person is no stranger to both live and virtual presentations. We have Dr. Lyman, who is a professor of medicine in the Division of Medical Oncology and at the University of Washington, and professor of public health sciences and clinical research at the French Hutchinson Cancer Research Center, where he serves as senior lead of healthcare quality and policy at the Hutchinson Institute for Cancer Outcomes Research. He's also an adjunct professor in the schools of public health and pharmacy at the University of Washington and at the School of Medicine at Duke University. Dr. Lyman is internationally recognized and an expert in oncology and hematology, comparative effectiveness and outcomes research, the conduct of formal systematic reviews and meta-analysis, and the application of mathematical and statistical models to enhance the clinical effectiveness and cost effectiveness of new diagnostic, therapeutic, and supportive care modalities. He's very active with the American Society of Clinical Oncology, and just some very brief highlights of his involvement include having served on the board of directors. He's also a member of the ASCO Task Force on Value of Cancer Care and the Task Force on Clinical Pathways, along with chairing several clinical practice guidelines for the society. Dr. Lyman's published more than 600 articles in medical literature with nearly 70,000 citations. He's authored or edited more than 20 medical textbooks and over 70 book chapters. He's listed as among the top 0.1% of investigators by citations in Web of Science. He's also an editor-in-chief in a number of journals, and including being on the editorial board of the Journal of Clinical Oncology. So Dr. Lyman's presentation today is the evolving value of myeloid growth factors for the prevention of febrile neutropenia. And now I'd like to pass it on to Dr. Lyman.
Thank you so much, Ed. And it's certainly a pleasure to be here and to work with you again as we've worked in the past. And welcome to everyone to the HOPA meeting, which is I think going to be a very stimulating meeting, and we're kind of launching things off on this issue, as Dr. Lee indicated, the evolving value of myeloid growth factors. This has been an area of particular interest to me over the years, going back to the very beginning of development of the colony stimulating factors and the evolution of clinical practice guidelines and integration into care, and of course now the role of biosimilars in trying to broaden access to these agents and rein in some of the cost challenges to patients and the health system. So we're going to cover a lot of material within the next 50 minutes or so. Hopefully there'll still be some time at the end for questions and answers and discussion. If you don't get your question answered, feel free to email me or Ed, or contact us, and we'll try to address it as well. So you should see my disclosures here. I've worked with Amgen on the early development of colony stimulating factors, and worked with many of the biosimilar companies as indicated here. And this program is sponsored by Sandoz. So the objectives are to describe the impact of chemotherapy-induced febrile neutropenia on clinical outcomes and healthcare costs, to describe the evolution of the recommendations for the use of these agents, both prior to the introduction of biosimilars and since then, including, of course, the interim guidelines released during the COVID-19 pandemic last year that remain in place. And then try to further explain the value of biosimilar myeloid growth factors on the prevention of chemotherapy-induced febrile neutropenia. So a lot to cover. I wanted to frame it in the context what we will call the value of myeloid growth factors. And to get away from the idea that it's just one thing that we're trying to do here. Of course, we're always trying to improve the survival of patients, and we know that fortunately less common than in the past, but even today, patients do die from neutropenic complications from chemotherapy, including febrile neutropenia. We also know that the growth factors may allow us to deliver higher or more complete dose intensity chemotherapy and potentially improve disease control and long-term survival from their cancer. So there's kind of a double impact potential with growth factors, reducing the risk of febrile neutropenia and improving chemotherapy dose delivery. Of course, quality of life and quality of care are fundamental to what we're interested in, and I will touch on the guidelines that have emerged and evolved over time. Extremely important, I know important to all of you, is the cost of healthcare, and it's a balancing act between the cost of these innovative but expensive products, the myeloid growth factors, and the cost of the complications of cancer chemotherapy, particularly febrile neutropenia and hospitalization and complications resulting from that, including extra visits, lab tests, time lost from work. It's a multiplicity of cost impact that we're trying to prevent. So balancing that cost, reducing the cost of the complications with the cost of the intervention is where we're trying to find the right mix for optimal patient care and without totally constraining the healthcare system. And then, of course, in today's era, more than ever, we're concerned about equity and the ability of patients and all patients to receive the same level and optimal level of cancer care. So access to these agents, both the novel therapies that have excited all of us, but the supportive care are fundamental. So this is our framework going forward, and we'll talk first about the clinical consequences of febrile neutropenia. As I said, it's kind of a double impact. On the left side, we know that chemotherapy, myelosuppressive chemotherapy, will reduce the neutrophil count and a proportion of patients who develop sepsis or fever in the setting of neutropenia, most of which will recover with appropriate antibiotics, often empiric broad-spectrum antibiotics. But many patients still today end up in the hospital. Some patients end up in the intensive care unit. So life-threatening complications occur. And as you'll see in data I'll show you in a minute, there are still deaths occurring every day from febrile neutropenia as a result of cancer chemotherapy. On the right side, of course, is the impact of these complications, neutropenic complications, on chemotherapy dose delivery, treatment delays, dose reductions, which is another way to reduce that risk. But unfortunately, it has a potential adverse effect on disease control. That is, reducing the chemotherapy beyond a certain point may reduce the chance of response, of disease-free survival or overall survival from the cancer itself, and which, of course, we want to avoid as well. So both of these are targets for improving the survival of patients with cancer. So the clinical and economic burden of febrile neutropenia obviously has a direct impact on the healthcare system as well as individual patients. There is a risk of early mortality of febrile neutropenia, as I just said, and we've shown that risk in the real-world setting in population data, it could be as much as 30–35% greater than for patients who do not develop febrile neutropenia but are otherwise matched in terms of disease treatment and comorbidities. We also recognize that appropriate prophylaxis is critical to minimizing that risk. And so, again, in retrospective studies, we've shown that about half of febrile neutropenia hospitalizations can be avoided with appropriate guideline-driven use of the myeloid growth factors. And it goes beyond what we've become used to, the stratifying of febrile neutropenia risk into low, intermediate, and high, where the high is generally routine prophylaxis with myeloid growth factors is recommended. And we know that and many patients who are receiving regimens at intermediate or even low risk sometimes still develop neutropenic complications and serious adverse events from those. So we'll talk more about that shortly. Febrile neutropenia incurs greater costs to patients and the health system. And unfortunately, in today's world, more and more of the costs of cancer care are being passed on to patients through copays, through caps and insurance policies. And so these complications and the cost incurred do directly impact on patients as well as our healthcare systems. And I think you all realize and don't need to be told that the economic burden of hospitalization is enormous in this country, and in fact has increased perhaps as much as 30 to 40% over the last decade and a half, and we'll come back to that. So this is just to highlight some of the work we've done in population studies looking at the impact of febrile neutropenia after matching cancer patients getting chemotherapy for their disease, their treatment, and their other health conditions. And of course, in the randomized controlled trials, we didn't see this much impact on survival. But these were highly selected patients who didn't have a lot of the comorbidities that we encounter in real world practice. The majority of cancer patients, because of age or other conditions, have one or more major medical comorbidities. And these are complicated by the episode of febrile neutropenia if it occurs, and appear to result in an increased risk of mortality, which at least in part, if not mostly, is a result of the febrile neutropenia intervening in their care. The other data we've looked at was prospective cohort study. We ran this over a decade and a half ago. And here look at a total of a little over 500 patients who developed at least one episode of severe or febrile neutropenia during the first 4 cycles of chemotherapy. And as we've seen on our previous studies, and others have confirmed, the majority of these febrile neutropenia episodes occur in the first cycle of chemotherapy. And this is nothing magical. The issue is the first cycle is when patients are most likely to be receiving the full dose of chemotherapy on schedule. And then if they develop a complication, there may be a tendency to reduce the dose, to add on a growth factor if it was not given as primary prophylaxis starting in the first cycle, or in some cases, antibiotics get administered, which may reduce the risk of infection, but in some patients, but not, of course, improve chemotherapy dose delivery. So overall, in this study, the febrile neutropenia risk across different cancer types, this was kind of an all-comers prospective cohort study, was 16.3%, but we found that among patients receiving chemotherapy at near full dose intensity, the average risk of febrile neutropenia across multiple cancer types receiving chemotherapy was 21% without growth factor prophylaxis, and fell to only 9% in those receiving growth factor prophylaxis. And you can see that illustrated in the chart on the left. So again, just confirming that the impact of chemotherapy on the risk of febrile neutropenia is very real in the real world. Half of febrile neutropenia hospitalizations in another retrospective study, Derek Weicker and colleagues have reported from claims data, looked at febrile neutropenia hospitalization and found that half of these were patients who were not receiving appropriate guideline-driven prophylaxis for febrile neutropenia. Study included nearly 60,000 patients receiving standard chemotherapy agents associated with a high risk of febrile neutropenia. 41% of febrile neutropenia hospitalizations occurred in this study did not receive appropriate prophylaxis with a myeloid growth factor, whereas those that did, again, it fell to just about 9%. So again, half of febrile neutropenia hospitalizations appear to be occurring in patients who should have received primary G-CSF prophylaxis but did not. So looking more deeply at the economic burden of febrile neutropenia, hospitalizations for febrile neutropenia obviously add significant medical cost, resource utilization, and this is particularly problematic in the era of the COVID-19 pandemic, where those resources are limited or strapped or devoted to other clinical activities. So in another retrospective claim database, again from Derek Weicker, looking at, we've found that patients that develop febrile neutropenia hospitalization, anywhere from 13 to 20% of them experience febrile neutropenia during the chemotherapy course across all cancers. And the majority of these, 90% or greater, required hospitalization. The risk was highest, as I said previously, in the first cycle of chemotherapy, somewhere between 20 and 35%. The mean length of stay in those that were hospitalized for febrile neutropenia was a little over a week. And even today, with the best antibiotics we have available, the inpatient mortality in patients hospitalized with febrile neutropenia it ranges between 4 and 10%, varying somewhat with cancer type and the type of chemotherapy they've received. And the mean cost of hospitalization, and this is data that's already 5 years old, was between $16,000 and $20,000 per hospitalization. So the cost is enormous and continues to grow as hospitalization costs continue to rise. This is just looking at another similar type of study using a retrospective data from the Premier Hospital database, around 16,000 patients hospitalized with febrile neutropenia. And here the inpatient mortality across cancer types was 10%. And that aligns pretty much with data we've seen from the University Health System Consortium, which has stayed relatively constant over a decade and a half, nearly 2 decades now, but remains right in the 8 to 10% range. The length of stay has stayed a little under 10 days, and the mean hospitalization costs, however, have continued to rise. In this study, it was close to $19,000 per febrile neutropenia hospitalization. And if you look at the chart on the left, you can see across cancer types, that the length of stay varies with the cancer type. It's lower in breast cancer, higher in patients with lymphoma or lung cancer. But the costs are all in that, pretty much in that range. Breast cancer a little bit less, but for most of these cancer types, it hovers around 20%. Again, has risen over the last decade and a half as hospitalization costs have. This is just some data from yet another study in breast cancer, again, looking over a more recent time period, 2009 to 2011. So this is a little more recent data from the nationwide inpatient sample database. And what they found was in breast cancer, again, the average mortality rate was somewhat less. These do tend to be somewhat younger patients, and perhaps that may explain part why the mortality rate from febrile neutropenia is a bit less, but the length of stay was a little bit less, around 6 days. But if you look at the mean hospitalization cost, if anything, it was a bit higher. And the authors try to figure out why their costs were higher than previous studies have shown. I think part of it, again, is it's more recent data, so it reflects more recent hospitalization cost information, but clearly that cost is incredibly high. Average hospitalization cost per febrile neutropenia hospitalization in the breast cancer setting in the real world was over $35,000 per episode. So if we look at non-small cell lung cancer, a little different setting. This is using data from SEER again, retrospective analysis looking at older patients that are Medicare, have Medicare. This is the SEER Medicare linked data. And just looking at non-small cell lung cancer, the risk of febrile neutropenia was about 10% in this setting. Neutropenia-related costs accounted for about a third of total healthcare costs in this population, tabulated by Medicare. And the mean all-cause healthcare costs, again, around $38,000, close to $38,000 from this data. So again, the cost of hospitalization with febrile neutropenia is very, very high, and is the balancing point, as we said at the beginning, between balancing that cost of trying to prevent these complications with the myeloid growth factors and reducing or obviating the cost of febrile neutropenia hospitalization in perhaps half or more of these patients. The mean neutropenia-related cost per patient per month during first-line chemotherapy was around $2,700, but the total mean neutropenia-related costs during this first-line chemotherapy, a little over $12,000. So I'd like to talk for a minute about the guidelines for the use of these agents. Obviously, we have a lot of data both from multiple randomized controlled trials that were the pivotal trials for these agents that demonstrated their efficacy and safety, but also now abundant real-world data from a whole range of large population data sets to attest to the fact that these are serious, persistent complications. They have a real mortality rate, and they have an enormous economic impact on patients and the healthcare system. So we began developing guidelines for the myeloid growth factors back in the early 1990s. We put out the first ASCO guideline on their appropriate use in 1994. Back then, we had only data on the use of these agents in high-risk patients receiving high-risk regimens, over 40%. And the cost data, incomplete cost data we had, just looking at the cost of the drug versus the cost of being in the hospital and no other cost considerations, came in around 40%. So that's where the threshold was set. There were a couple of updates. Then in 2006, so about a decade later, we updated the guidelines based on data that had emerged on the role of these agents in preventing febrile neutropenia in patients getting intermediate risk chemotherapy. And we had new cost data that included not only the rise in hospitalization costs that you've just seen, but the cost of other aspects of care that are increased with the use of cancer chemotherapy and now modern therapeutic efforts. And that brought the threshold risk for a cost minimization assessment down to around 20%. So the risk threshold was set there. Anything above that the recommendation was for routine primary prophylaxis in cancer patients receiving cytotoxic chemotherapy. Of course, a decade after that now, we have the introduction of biosimilars, and we'll talk more about that in a minute. Then just recently, those biosimilar myeloid growth factors have been integrated into ASCO guidelines. Subsequent to that, included in the 2015 update from ASCO and the 2015 and 16 updates from NCCN. And then this past year, and we'll talk about this a little bit more, with the onset of the COVID pandemic and the stress on the healthcare system and the need to keep patients away from the hospital where they might get co-infections, and also consume limited healthcare resources. The indications for the use of myeloid growth factor primary prophylaxis were broadened, as well as therapeutic use of these agents in patients who develop febrile neutropenia. So this just shows the timeline of the introduction of the myeloid growth factors. So we started with the cloning of GCSF. My history with this actually goes back before that time, but that was an exciting time when we finally kind of learned what was responsible for responding to sepsis and neutropenic complications in patients receiving cytotoxic chemotherapy. Filgrastim was licensed in the EU and in the US in the early 90s. We learned later in the 90s that by pegylating filgrastim, they could extend the half-life so that perhaps daily short-term injections with these agents for a week or two would not be necessary to maintain recovery from myelosuppression. And then in early 2000s, after several clinical trials, the pegfilgrastim, the original pegfilgrastim, was licensed again both in the EU and the US. And the pegfilgrastim was found at that point to have comparable safety and efficacy to daily full course filgrastim. The first filgrastim biosimilar was licensed in the EU about a decade ahead of the US, well, not quite a decade ahead, about 6 years before it was approved in the US in 2015. Reference pegfilgrastim was found in comparative trials with filgrastim to perhaps be a little bit more potent. I think that remains somewhat controversial, but it certainly has been our experience that by giving pegfilgrastim a sustained duration on long-acting myeloid growth factor, you can obviate what often is the case of patients not getting the full recommended dose and schedule of filgrastim on a daily basis for the full course. And therefore, pegfilgrastim in real-world data has been shown in some studies to have a greater efficacy in reducing febrile neutropenia. So the first pegfilgrastim biosimilar was licensed in the US in 2018, and particularly the BMEZ. We now have 4 biosimilar forms of pegfilgrastim. The BMEZ was licensed in 2019, and we have, of course, 2 biosimilar filgrastims. So we have 6 options there combined with the 2 reference products. So in the current guidelines, we've integrated these right into recommendations for use for preventing febrile neutropenia. I'd like to just come back for a minute to some of our modeling work, looking at cost effectiveness, which we've recently updated. So our original models were just simple cost minimizations studies. You can see the decision tree on the left. And based on hospitalization costs, the febrile neutropenia risk thresholds where cost savings are seen, balancing out the cost of the growth factor. The cost minimization threshold came in around 20%. And again, that was aligned with data that these agents were effective in patients receiving intermediate risk regimens, demonstrating effectiveness at that level. So the rapid increase in understanding of clinical quality of life and economic impact of neutropenic complications and their management, we recognized it was essential that guidelines be continually reevaluated and updated, including the integration of biosimilars. And you can see here the current recommendations for both primary and secondary prophylaxis from ASCO on the left and NCCN on the right. Again, the NCCN guidelines are a little more nuanced in that they divided regimens into high risk, more than 20%, intermediate risk, 10 to 20%. So high-risk patients are recommended to receive routine neutropenic prophylaxis with myeloid growth factors. Intermediate risk, if a patient has additional risk factors for febrile neutropenia, and they're listed there, then certainly the consideration and use of myeloid growth factor primary prophylaxis was encouraged. And then, of course, if patient doesn't get a myeloid growth factor with the first cycle but develops a neutropenic complication early in their disease course, secondary prophylaxis is recommended. So these are pretty much aligned, a little bit of difference in the language and structure of these guidelines, but they pretty much have aligned, including the most recent guidelines integrating biosimilars into the myeloid growth factor recommendations. As I mentioned earlier, COVID-19, as you all know, I'm sure extremely well, has impacted on our healthcare delivery, particularly in the cancer delivery system. Last March, we launched a national registry, which is now an international registry of patients with cancer and confirmed SARS-CoV-2 infection. This has led to a large cohort study. The initial month of activity of this cohort, accruing patients from throughout the country from now over 100 institutions. There were 1,000 patients with cancer and confirmed COVID-19 tabulated. This was reported in The Lancet in two separate publications. You see referenced at the bottom. You can see that the average age of these patients was 66, with breast cancer and prostate cancer being the most prevalent. About half of these patients ended up in the hospital. So again, these are cancer patients with confirmed COVID-19. A quarter of them had severe COVID-19 by CDC classification. About 12% of them ended up in mechanical ventilation. But very importantly, the 30-day mortality from COVID-19 in the cancer setting, it was 20% overall across cancer types, and even a bit higher in the hematologic malignancies, myeloma, lymphoma, leukemia patients at an even greater risk. This led to an update interim recommendations from both ASCO and NCCN. And you can see here the interim recommendations, again, pretty much aligned, although a bit more detail in the NCCN interim recommendations that were published, showing that in addition to recommending routine myeloid growth factor prophylaxis, primary prophylaxis in patients receiving high-risk chemotherapy, we felt it was important to extend that recommendation to routine primary prophylaxis in patients receiving intermediate risk chemotherapy in the 10 to 20% range. So we changed the threshold for growth factor use in this setting from not only high-risk patients, but to intermediate risk or high-risk patients. And then we also expanded the use in the therapeutic setting. Historically, we had not recommended routine use of growth factors except in certain selected situations in patients who developed febrile neutropenia but had not been on myeloid growth factors. But we felt, again, to reduce their exposure to the healthcare system, their risk of co-infection if they develop COVID-19, that these patients be considered for growth factor treatment to accelerate their recovery from febrile neutropenia complications and to reduce the risk of adverse or fatal outcome from sepsis while recovering from their COVID-19. So these are meaningful guidelines that remain in place because the pandemic is very much still with us. We're seeing what may be early signs of a fourth surge nationally, and of course in Europe and many parts of the world, COVID-19 pandemic persists and in some places has increased. So this problem is far from over, despite the now over 100 million Americans having been vaccinated. The need to protect these patients who are particularly vulnerable remains. So just in the last few minutes, talk about some of the gaps in our understanding of febrile neutropenia prophylaxis. And one paramount one alludes back to this issue of what to do with patients getting intermediate risk chemotherapy. Again, historically, these patients, and these are just some examples from the NCCN guidelines that stratifies not all chemotherapy regimens, but many into high, intermediate, or low risk of febrile neutropenia based on clinical trials. Yeah, and you can see for breast cancer, for non-Hodgkin's lymphoma, and for lung cancer. So again, historically, the guidelines had recommended routine prophylaxis in high-risk regimens, but not routine use in patients getting intermediate risk regimens, such as those illustrated here. And but with the interim guidelines now during the pandemic and continuing to the present time, these patients are encouraged to be considered for primary prophylaxis with a myeloid growth factor for the reasons that I've stated. So again, with the current versions, these patients become prime candidates for primary prophylaxis with myeloid growth factor. So we've looked at the impact of growth factor and the risk of febrile neutropenia in this intermediate risk cancer chemotherapy setting in real-world data. Again, some work that I did with Derek Weicker, looking at a retrospective U.S. healthcare claims data, looking at intermediate risk chemotherapy regimens, or what we call here, patients not classified as high risk because we included both low and intermediate risk chemotherapy regimens if they were not strictly classified. So these are patients who are receiving intermediate risk chemotherapy or a chemotherapy regimen that we could not put into the categories defined by NCCN. So we called that unclassified. We identified 17 common cancer/regimen combinations, so around a little over 160,000 patients over about a 10-year period. The majority of these patients, as you can see here, depending on the cancer type, the vast majority had one or more other risk factors for febrile neutropenia, as we've talked about earlier. And in fact, anywhere from 40 to 90% of these patients had two or more febrile neutropenia risk factors, in addition to the cancer and the chemotherapy, intermediate risk chemotherapy they were receiving. So the majority of patients in the real world getting intermediate risk chemotherapy have other risk factors that really need to be considered in the decision, even pre-pandemic, for the use of myeloid growth factor, and where the guidelines said you could consider primary prophylaxis because of these additional risk factors. So when we look specifically at patients who had one or more risk factors, we said that was the majority of patients. Febrile neutropenia occurrence ranged from 7 to nearly 30% across regimens and across cancer types. And if we looked at patients, the relative risk for febrile neutropenia versus those without risk factors range from a little about 10% increase to more than a doubling of risk of febrile neutropenia compared to those getting intermediate risk chemotherapy without these additional risk factors. So these risk factors, in addition to, again, the cancer and the type of chemotherapy they're getting, do play a major role in defining their ultimate risk of febrile neutropenia and hospitalization from febrile neutropenia. So looking at another set of data looking at the same type of situation, you can see here data from 2018, looking at an EMR database from 52 health practices across 145 sites, more than 200,000 patients receiving chemotherapy between 2013 and 2014. And you can see for both non-metastatic, looking at the lower left-hand panel, or metastatic patients receiving chemotherapy, the risk of febrile neutropenia in the intermediate risk patients with no thromboprophylaxis really was very much influenced by whether they had one or more additional risk factors. In the metastatic setting, nearly 2/3 of these patients who had additional risk factors for febrile neutropenia, and about half of the patients in early stage disease had additional risk factors. So again, in the pie chart on the right, just looking at it a little more closely, about 9% of these patients were receiving high risk chemotherapy. Of course, importantly, is not all those patients were getting guideline-recommended primary prophylaxis. About 2/3 were, but almost around 40% did not receive G-CSF prophylaxis in the real-world setting. So that's a problem, just non-adherence to even the historical guidelines. If you look at the low-risk patients in the light blue, you can see these are patients who would not routinely get primary prophylaxis. About 11% did, and that may be appropriate depending on the other risk factors that they had. Very importantly, the largest slice of this pie are the patients getting intermediate risk chemotherapy. And you can see here, this counted for nearly half of the patients in this more than 200,000 patients, and less than 30% receive primary prophylaxis, even though, as you see, half to 2/3 of them had other risk factors for febrile neutropenia that would have justified and, in fact, encouraged primary prophylaxis. So this may be a gap, either a knowledge gap or an implementation gap that could lead to improved care of these patients. There's been looked at patients' febrile neutropenia-related hospitalization within a large integrated delivery network. This is from the Kaiser system, looking at adults over 18 or greater with any stage of breast, lung, or cancer or lymphoma, non-Hodgkin's, who initiated myelosuppressive chemotherapy between 2006 and 2009. You can see the numbers of patients, a substantial data repository. And you can see for breast cancer patients, about 20% receive primary prophylaxis. You can see, again, patients who develop febrile neutropenia, most of whom were not getting primary prophylaxis. You can see that many of them developed febrile neutropenia. There was still a real mortality rate, length of stay, and a true cost of hospitalization. So again, the potential for preventing these complications. In lung cancer, the mortality, again, was somewhat higher. In fact, all-cause mortality in hospitalized patients with neutropenic complications with lung cancer was around 25%, and the cost over $30,000 per episode. Similarly for lymphoma, although the mortality rate wasn't quite so high, it was kind of in between breast and lung cancer patients, the cost per episode of febrile neutropenia hospitalization extraordinarily high, over $35,000. So all of this meaning we still have gaps in our care and opportunities to both reduce complications, reduce mortality, and reduce costs. I just wanted to mention an ongoing study. Actually, we completed accrual in the study, which was funded by PCORI, the Patient-Centered Outcomes Research Institute, and has been run over this past 2 years through the SWOG Cancer Research Network and through the NCORE system, the community practices affiliated with SWOG. And this is called the TRACER study. We've published basically the rationale and design this past year. And early in the pandemic, back in April, we completed accrual of the study and are currently analyzing the results, which we hope to present and publish later this year. I just wanted to make you aware of the study because this is a large pragmatic trial across the NCORE network of SWOG, looking at the use of myeloid growth factors according to clinical practice guidelines. We use the NCCN guidelines as the framework for defining appropriate use here. And we felt that there was limited high-quality evidence at the practice level for the use of these agents, a secondary question of their potential impact, again, in patients receiving intermediate risk chemotherapy. So again, this is a prospective clustered randomized control trial, meaning it was not the patients who were randomized, but the sites, the practice sites participating in the network that were randomized to either, number one, automated order entry for primary prophylaxis according to NCCN guidelines versus sites that were randomized to just do their usual practice routine care. So sites were randomized to either primary prophylaxis integrated into their computer order entry system. So it was dictated, or you could opt out of it, but it automatically would, for high-risk patients, would integrate primary prophylactic CSF. For intermediate risk regimen only if they had multiple other febrile neutropenia risk factors. And this was compared to sites just doing what they normally would do. And then nested within this was a second randomization for the sites that were involved in the computer order entry guideline implementation to randomizing half the sites to receive primary prophylactic G-CSF for intermediate risk chemotherapy. So any patient getting intermediate risk chemotherapy at a site randomized for this group would automatically also get primary prophylaxis versus standing orders that prohibited or recommended against primary prophylaxis for intermediate risk chemotherapy. So we hope to answer two questions. One is whether integrating the guideline recommendations into your order entry system for automatic integration would improve adherence to guideline recommendations. And number two, to provide more data where we have very little data on the impact of primary prophylaxis in patients getting intermediate risk cancer chemotherapy. And the primary outcomes here will be the rates of febrile neutropenia overall and in patients getting intermediate risk chemotherapy. So again, in the last couple of minutes, I would like to talk about the biosimilars and what has happened here. Of course, the goal of biosimilars is both to improve access to costly therapies. And now we have, again, the multiple biosimilar myeloid growth factors I mentioned, 4 pegylated versions and 2 filgrastim versions, and as well as multiple targeted therapies and monoclonal antibodies for cancer treatment, including trastuzumab, rituximab, and bevacizumab, and so forth. But the other goal here is to see if we could begin to rein in the cost of these drugs. And we just illustrated here for filgrastim on the left and pegfilgrastim on the right. From this study was published in the JAMA Network Open, looking at list price of these supportive care agents, filgrastim, pegfilgrastim, as well as their net price that was reported. And it's a good news, bad news story. We would, of course, love to see the list price go down dramatically, but we knew it wasn't going to happen, particularly in the U.S. and particularly in a setting where competition was only beginning. These biosimilars are only available, many of them only the last couple of years. But being an optimist, I'd like to think that the list price actually has begun to flatten for both agents since their introduction of biosimilars. And perhaps more encouraging is the net price reported for these agents, which has shown, at least in the last year of data available, in the last couple of years for filgrastim and the last year for pegfilgrastim, a real reduction in the net price for these agents. So this is encouraging. Of course, not the dramatic reductions we see with generics for small molecules, but hopefully a trend that will continue over the coming years as more and more biosimilar competition enters the healthcare marketplace. So I'll just kind of close with a study that Ed Lee, and Ed, you can certainly chime in as when we go to the Q&A, but looking at primary prophylaxis with one of the biosimilars, filgrastim SNDZ. You know that all biosimilars have this 4-letter suffix This was the first approved biosimilar in the U.S. form of filgrastim, and look specifically at the intermediate risk setting and do a cost effectiveness analysis based on data available from multiple sources. You're all familiar with the cost effectiveness map and looking at the trade-off between incremental cost with the vertical axis and the incremental effects or efficacy on the horizontal axis. And obviously, if there's an increase in cost and reduction in efficacy, you're going to reject that approach. And if there's a reduction in cost and an improved outcome, you're probably going to automatically accept that. But where most of the data falls is in this upper right-hand part of the plot and trying to define the maximum acceptable incremental cost effectiveness ratio. So the incremental cost per event prevented or life years or quality adjusted life years. So that was kind of the standard framework for looking at cost effectiveness of this agent. So in this particular study, we chose to evaluate the cost effectiveness of primary prophylaxis versus secondary prophylaxis. So waiting until an event actually occurred and prophylaxis with the filgrastim SMDZ in 3 disease settings, non-Hodgkin's lymphoma, non-small cell lung cancer, and patients with breast cancer receiving curative therapy. So these are patients, most lymphoma patients treated with curative intent, early stage lung cancer, early stage breast cancer, and receiving a regimen classified as intermediate risk by NCCN. We undertook a Markov modeling effort and constructed, which was constructed to evaluate total cost of healthcare for neutropenic complications and the cost of growth factor use, either as primary prophylaxis or secondary prophylaxis. So included in the model are non-Hodgkin's lymphoma patients with no additional risk factors, which which represented a febrile neutropenia risk without growth factor prophylaxis around 18%. Non-small cell lung cancer with 1 additional risk factor, illustrated by carbotaxol, with about, based on trials, about an 18% risk of febrile neutropenia, or early stage breast cancer with 1 additional risk factor receiving adjuvant docetaxel, and the baseline risk was around 16%. So our outcomes were looking at cost of FN event avoided, life years gained, or quality adjusted life years gained. And a sensitivity analysis was done because obviously there are uncertainties or variation in these estimates that populated our model. So we looked at patient characteristics. These were intermediate risk, patients getting intermediate risk chemotherapy, the practice setting. So it was either primary prophylaxis or secondary prophylaxis with filgrastim SNDZ. And then we tabulated the incremental effectiveness on outcomes based on preventing febrile neutropenia mortality, preventing dose reductions, treatment delays, and higher cancer recurrence rates, and total incremental effectiveness of the primary versus secondary prophylaxis, and then the incremental cost, including drug costs, hospitalization costs, administration costs, emergency room visits, and so forth. So that's the basic schema. Again, this Markov model based on cycle 1 analysis shown at the top, the comparator for primary versus secondary prophylaxis, and then patients experiencing febrile neutropenia or not in that first cycle, and then if they died or not as a result of febrile neutropenia. Patients who survive, they go on to the subsequent cycles, and we modeled here cycles 2 to 6. Again, either FN or not in each cycle, and either survival or not from these. And then post-treatment, looking at the delivered dose intensity and the risk of cancer recurrence and mortality. All this modeled using the Markov process. This just summarizes the model parameters. And I know I'm going over this quickly, but the publication reference, which was just published this past week or two, in the Journal of Clinical Oncology. Oncology Practice is cited at the bottom here. So the relative risk of febrile neutropenia in using filgrastim prophylaxis versus no filgrastim prophylaxis was 0.42. So over nearly a 60% reduction in the risk of FN. The cost of growth factor was based on average sales price from CMS mid-July. And the febrile neutropenia events consider the cost of patients treated as inpatients versus outpatients based on, again, real-world population data, hospital length of stay data in both of these settings, and the relative dose intensity delivered, again, based on population data, much of which I've gone over earlier. The utilities associated with these complications were integrated for the quality of life analysis, and then mortality was considered during a hospitalized FN event, and for different relative dose intensities. This just shows the results over all three cancer types combined, showing the estimated cost of care, the life years gained, the quality adjusted life years gained, and then the ICER, the incremental cost per febrile neutropenia prevented, ranging from $5,000 to $20,000, well within that boundary. And then, of course, ICER for the cost per life year gained by preventing early mortality or cancer recurrence mortality between $5,000 and $30,000 or $35,000 for quality adjusted. So again, for non-small cell and for lymphoma, most influential factors were the baseline risk, mean hospitalization, length of stay, and the cost of FN requiring hospitalization. And for breast cancer, it was the baseline risk of FN mortality and the hazard ratio for low RDI and relative risk for FN with primary filgrastim versus secondary filgrastim. And this just plots these ICERs on the cost effectiveness plane. As you see here, all of them falling below the willingness to pay threshold of that we've often used of $50,000 per quality adjusted life year. And this just illustrates the sensitivity analysis the one way as well here based on the acceptability curves. And you can see here there was anywhere from 74% to a 99% probability that primary prophylaxis with filgrastim SNDC was cost effectiveness at the willingness to pay threshold of $50,000 per quality. And this is across cancer types. So our study conclusions were primary prophylaxis with filgrastim SNDC is cost effective. This in patients getting intermediate risk febrile neutropenia based on their regimen and receiving curative chemotherapy for the three common cancer types we mentioned. And then the expanded use of growth factor based on further contributes to efficient cancer care management given facility resource use and labor constraints during the COVID-19 pandemic while maximizing the potential for cure. Obviously, we do hope that the introduction of biosimilars will continue to be integrated into clinical care, into guidelines. This recent report from the Pacific Research Institute, which I was not involved with, but just highlighting the fact that according to their analysis, the majority of states across the U.S. Benefit less than $5 million in annual savings from their current utilization of biosimilars. Nationally, it's around $240 million. However, they estimate that if biosimilars were to achieve upwards of 75% of market share, that their total healthcare savings could be in the billions of dollars. They estimate around $7 billion per year. And state Medicaid programs could save over $1 billion, and commercial payers even more than that. So this obviously is conjectural, but it certainly points to the real potential for impacting on healthcare costs And I would say also reducing the cancer burden, economics, and healthcare impact of cancer treatment on patients with cancer. So our summary, febrile neutropenia, if not prevented, is a major cause of morbidity, mortality, and cost in patients receiving chemotherapy, while the prevention of febrile neutropenia in high-risk patients has previously been addressed by guidelines. There are real opportunities to continue with the current interim recommendations to consider primary prophylaxis in patients getting intermediate risk chemotherapy, particularly if they have other risk factors and beyond. Biosimilars are helping to, we would conclude, improve the value proposition of myeloid growth factors for the prevention of febrile neutropenia. And I'll close at that point and turn it back to you, Ed.
Great. Thank you, Dr. Lyman. We are just 2 minutes over time right now, but I never mind getting more from you and hearing more about your expertise. So thank you so much for this presentation. If you have the time, we do have one question that really just asks about what are the key concepts for the COVID GCSF updates in the ASCO and NCCN guidelines. So if you don't mind briefly answering that.
Yeah, I think, again, these interim, what they're called interim recommendations, are still in place and probably will continue at least through the end of this year. And we'd like to think not necessarily beyond that, but my sense is, and I said on both panels, is that the advantage of preventing these complications and keeping patients out of the hospital as hospital costs have continued to rise, and reducing the stress on the healthcare systems, the providers, the caretakers, the nurses, in the entire healthcare team, that the advantages of reducing that stress will be quite apparent to almost everyone, even as the infection rate from COVID-19 falls and hopefully eventually disappears. And we don't know when the next pandemic will come. So my anticipation, of course, you need to follow these things may change over time, is that many of these recommendations will persist well beyond the pandemic. And these advantages, which were previously based on just limited randomized controlled trial data, we now have, again, as I've went over in some detail, real world data and now cost effectiveness data to say there's a real value in doing this independent of the pandemic issue, both in reducing mortality, improving quality of life, and reducing costs or improving the cost effectiveness of our care. So I think these recommendations, if not entirely, many of them are likely here to stay for the foreseeable future.
Great. Thank you so much for that perspective. And again, it's just been wonderful to hear your historical perspective on this and how you've been involved in all of this since the beginning. And it's just great to kind of hear these updates about kind of where we've been and where we're going. So again, thank you. And thanks to everyone who attended this session. I know we're a little bit over time. And I hope you all enjoy the rest of the meeting. Thank you. Take care and stay safe.
Yeah. Thank you very much. Enjoy your meeting.